Good evening. I'm Troy Alexander, Associate Director of Public Affairs for the Texas Medical Association. Thanks for joining us tonight for TMA's Tele-Town Hall on Zika. Over the next hour, you will learn about the Zika threat in Texas from our state's top public health official and other foremost physician experts. You'll learn where cases have been reported in Texas, about response and prevention efforts, and the importance of prevention among pregnant women, and about protecting our blood supply. You'll also learn about screening for Zika, including guidelines for which patients should be screened. We also will ask for your feedback in response to several polling questions. All of this should take just over half an hour this evening. We will spend the rest of the time answering your questions. If you also wish to follow along tonight to see our presenter slides, we have posted the presentation on the TMA website. Please visit www.texmed.org/Zika, Z-I-K-A. Tonight I'm pleased to be joined by a group of Zika experts who will walk you through what you need to know for your practice and your community. Dr. Susan Rossmann discloses that she is a principal investigator for Roche Pharmaceuticals. The other speakers and planners have nothing to disclose. Our moderator this evening is Dr. David Lakey, Chief Medical Officer and Associate Vice Chancellor for Population Health at the University of Texas System. Dr. Lakey is also a former Texas Commissioner of Health, and he currently chairs the TMA Council on Science and Public Health. Good evening, Dr. Lakey.
Thank you, Troy. Your Texas Medical Association leadership wants to make sure Texas physicians are informed about Zika and how best to counsel your patients to care for them. Therefore, when the Department of State Health Services asked the Texas Medical Association for help in reaching out to our physicians about this public health threat, we organized this call. We know patients are concerned about Zika, and we want to empower physicians with as much solid, valid, current public health information as possible. We have a strong lineup of some of Texas's foremost physician experts about Zika and public health. I'd like to point out two resources for more information. Please visit the Department of State Health Services Zika webpage at www.texaszika.org. Texas Zika is all one word. Or the TMA Zika resource page at www.texmed.org/Zika. In addition to maintaining this TMA webpage with the latest information, TMA physicians have testified to the Senate Health and Human Services Committee and convened a Texas work group composed of physicians from different TMA committees.
Thank you, Dr. Lakey. Before we hear from our next physician expert, I want to ask everyone our first poll question this evening. You'll be able to respond to this poll by pressing a keypad on your phone. Here's the question. Which of the following points about Zika remain unknown? Press 1 on your phone keypad if you think we don't know the proportion of pregnant women with Zika infection in areas with Zika transmission. Press 2 if you think we don't know the likelihood of the developing baby getting infected from the mother. Press 3 on your keypad if you think we don't know the proportion of developing babies that develop an abnormally small head associated with incomplete brain development, or microcephaly. Press 4 if you think we don't know what factors increase risk to the developing baby. And press 5 on your phone if you think we still don't know the answer to any of these Zika questions. We will tabulate the results and report them to you later in this call. Back to Dr. Lakey.
Thank you, Troy. Now I would like to introduce our current Commissioner of Health for Texas, Dr. John Hellerstedt. Dr. Hellerstedt is a board-certified pediatrician and leads one of the state's largest agencies with a staff of 12,000 and an annual budget of $3.3 billion. With the passage of the Sunset legislation, the department is in transition, but he oversees programs such as disease prevention, disaster preparedness, family and community health services, environmental and consumer safety, and regulatory programs. I also want to note that Dr. Hellerstedt has been a TMA member since 1981. Prior to becoming the commissioner at the start of this year, Dr. Hellerstedt served as the chief medical officer at the Seton family of hospitals here in Austin. Dr. Hellerstedt.
Thank you, Dr. Lakey. Appreciate it. Thanks, everybody, for having me here. I'm going to jump right on in. Our first slide, actually the second slide, is really kind of a wrap-up. You can see there the global, the United States, and the Texas perspective. And obviously, Zika has been around for a fairly long time when it was discovered or identified characterized from the Zika forest in the Congo in 1948, but has made a splash in the Western Hemisphere since it basically invaded South America, Central America, and the Caribbean. You can see there in the United States, we have both travel-related cases now and also some locally acquired mosquito vector-borne disease, right now confined to Florida. There's a laboratory-confirmed case and a total of 2,964, at least as of the time of the printing of this, with 24 of those being sexually transmitted. The U.S. territories have a significant number of cases, and that's really where part of the crisis is right now, not just in Central and South America, but in Puerto Rico and the Caribbean. In Texas, we have, as of today anyway, 174 confirmed cases, directly or indirectly travel-related. That is to say, there are no local mosquito vector transmission in Texas to date. Of the folks that we've identified and we know had or had really Zika in most cases, 11 cases were pregnant, 2 were infants that were infected before birth, and 1 case was sexually transmitted, and in fact, that case really sort of put sexual transmission on the map. And if you look at the numbers, there's concern that there's a surprising number of sexually transmitted cases, and it may turn out to be a significant vector in this outbreak. I want to make sure people understand, though, that what we expect in Texas is not what we have seen in South America, Central America, and the Caribbean. We will most likely experience small flare-ups of local transmission by mosquitoes that may occur at some point. That could occur this mosquito season. That could occur next year. I'd like to underline the idea that Zika is here to stay for a while, and so this will not be the last mosquito season that we have to have concern about this disease. We believe that there are some areas that are at higher risk, and really those are around the population areas. So the disease is transmitted by mosquitoes, but it's really spread by human beings. In other words, it's spread by human beings who have the infection, come into a particular area, then while they have active viremic infection, get bitten by mosquitoes, the Aedes aegypti mosquito in their neighborhood, and that's how the local mosquito vector transmission begins. And it takes, again, that combination of lots of people and lots of the right species of mosquito in order to spread the disease. I didn't know much about mosquitoes before becoming the commissioner for the Department of State Health Services. I can't say I know a lot now, but I know a lot more than I did. There are about 85 different species of mosquitoes in Texas, and only a few of them have any relationship to disease spread. And in the case of Zika, we were really most concerned about the Aedes aegypti mosquito. If you look on slide 3, quickly you can see a tally of the 174 reported cases of Zika in the various counties. And here again, I'd like to really point out that you see the highest number of cases where there's really the greatest population. So you'd expect that because that's going to have the greatest number of travelers, and that's going to have the greatest population density. And that's population density, in my mind, is one of the greatest factors in the transmissibility and the sustainability, really, of transmission of Zika. Next, on slide 4, we have finalized and updated our version of the state response plan for Zika. It is posted on our website, again, www.texaszika.org. I would urge all of you to go there. It's got great information for healthcare professionals. It's got great information for your patients as well, and we do have our state plan posted there. We have distributed the plan to local health departments. The original draft was updated with community input, merging information and feedback from experts, including the Governor's Task Force on Infectious Disease, of which I am director, and we have great participation. We have physicians, we have county judges, we have attorneys. We really have a vast array of experts there to advise us, not just on the medical piece of it, but also on the public health and, if you will, emergency response aspects of our response to Zika. The plan is divided into 3 levels of response. Level 1, fortunately, we're still at right now, and that's prior to local mosquito vector transmission. Level 2, where we have identified our first potential case of local transmission. Level 3 would be sustained local transmission. And we have information there on how we would manage our communications and the public health and medical information. We have information about mosquitoes surveillance and control, human surveillance, command, control, and coordination. On the next slide, we want to talk about the strategies that we're trying to put into action with Texas Zika. We want to protect our most vulnerable Texans, and that must, in a way, make scientific and public health sense. And obviously, our most vulnerable Texans are our pregnant moms and the babies developing in their wombs. Right now, areas of focus to ensure that we're doing everything we can to delay and prevent Zika. One is communication precautions. And so one of the things I think to point out is the fact that we are forewarned about the dangers of Zika puts us really way ahead of countries like Brazil, who basically didn't see it coming until it had really pervaded their population, and they began to see the severe birth defects that are a cause. We've been able to see it coming, and so as a consequence, I think we have great advantage in that way. I think the other important thing is to really articulate what to expect. One of the principles really of managing an emergency type situation, a disaster situation, a situation like Zika where there's a lot of anxiety around the danger that it presents, is to really articulate the truth, stick to the facts, and that's very important here. And in particular, the fact that we do not expect to see the kind of really rampant, widespread epidemic of like they see in Central and South America and the Caribbean is extremely important. What we expect to see is more like what you've probably read about and seen in Miami, Florida, where you have relatively small areas of outbreak where we can identify those, we can define those areas, and we can respond with a great deal of intensity in terms of the kind of countermeasures that we can bring to bear to Zika. We certainly should expect local transmission. Again, I think if it doesn't happen this season, it will very likely happen in some future season until we find a way, whatever the way that is, to eradicate Zika. As I spoke about, defining the area is very important because defining the area has a lot to do with defining who is at risk and therefore who should be offered testing, particularly for pregnant women. As you know, we believe that 70 to 80% of the cases of Zika have no symptoms whatsoever, so you really don't have that symptomatology to rely upon for the timing of testing. And so if there's an area of active mosquito vector Zika transmission in a geographic area, we want to be able to offer testing to all the pregnant women in that area. And so being able to define what that area is and match our capacity for testing with the demand for testing is extremely important. I will tell you, one of my greatest worries is that we would get in a situation where there was a lot of panic and anxiety around Zika and women were making irreversible decisions about their pregnancy based on fear and not based on our ability to provide them with some objective scientific testing. So again, having people understand what to expect so that when we have a response to it, it's the response that they expect. The manager for emergency management within the state of Texas and I were talking about this the other day, and he is a emergency medical technician by licensure, and back when he was a firefighter, he said people would call 911 and ask for an ambulance, and he would show up in the fire truck and they would be disappointed that there wasn't an ambulance there, and he'd say, well, wait a minute, it's Nim Kid, I'm finally recalling his name. Nim Kid said, well, you know, I would explain to these folks, I am an emergency medical technician, I have all the equipment in my truck, I'm here to take care of you until the ambulance gets here. But so the response in that case was the right response, but it wasn't the response that the person expected. And I think that's, again, a really key to our planning here in our response to Zika, because people need to see the response they expect, and that'll be the response that they trust. On the next slide, again, talking about communicating and educating clearly about prevention and recruit community leaders to help amplify that message. Here again, one of the great lessons, ironies, if you will, about Zika is that if it comes here and we have local mosquito vector transmission, the countermeasures, the tools that we have at our disposal to fight that are exactly the same tools that we have at our disposal right now that if we put into play, we could potentially, again, delay or even prevent the arrival here, and particularly the sustained transmission by mosquito vector. So a lot of it is to create barriers against mosquito bites, and that's repellents and clothing, long sleeves, long pants clothing if you can manage it in the heat. Create barriers in human habitats, screens and air conditioning. Deny breeding habitats, that's getting rid of standing water, using larvicide around the home if you can't get rid of that standing water. And lastly, spraying with what we call adulticide, in other words, spraying for the adult mosquitoes when they're out in your yard. Something very important to understand about the Aedes aegypti mosquito, it feeds exclusively on human beings and non-human primates. So if people have pet monkeys, I guess they're at a little extra risk, but otherwise it's really about people. The mosquito loves to live right around your house, right, even in human habitations. So the kind of measures, countermeasures that people can take, many of it is within their control of themselves because it's right there in their home, it's around their property, it's their ability to use those barriers like repellents and clothing. So what we're trying to do is get out there and educate and create awareness. This is a big part of it. We have had public awareness campaigns where we've gone out and bought media. We've had webinars and educational opportunities. We've provided guidance documents to schools and daycares, and we've had seminars and other gatherings to talk about Zika from a planning standpoint. Again, we really hope that you will take an interest in Zika and stay on top of what's going on in the state. We do expect small pockets if it comes here in terms of mosquito vector transmission rather than widespread transmission. And then that means that our response to those outbreaks will be defined by the area that we find it in. People, as I said earlier, will be alarmed if they don't see the response that they expect. But right at this point in time, the openness and candor is what really builds trust. I must say I'm really kind of, in a sense, encouraged, if you will, by the response that I've seen in Miami. I was worried at one point that if there was a local mosquito vector transmission within the continental United States, that basically people would completely freak out. And there would be widespread anxiety and panic and the kinds of behaviors that you would expect to flow from that situation. I don't believe that that's what we're seeing, so that's very encouraging, and I think a lot of that has to do with the advanced planning that's gone into communicating to folks about what to expect. The CDC has helped in that regard. If we get local transmission, again, we will redouble our efforts that we have. We do have some assets at the state level that we can bring to bear in communities if they don't already have sufficient response teams, in other words, teams that can go out and do the epidemiological investigation, to do the zoonosis, or rather, I'm sorry, integrated vector management in those areas and help investigate and define the parameters of a local outbreak. We would be targeting, again, our integrated vector management within 150 meters if we have vector transmission. Again, that's because that's where the mosquito only flies about 150 meters in its entire lifetime. So when you think about it, that really means that you and your neighbors have a great deal of control over the risk of Zika in your particular community. On the next slide, we do want to be on very high alert and act fast when we think that we see a signal that local transmission has occurred. When we do that, we're going to work together to analyze and respond to the evidence of possible transmission, and that means taking a great history, getting our epidemiologists out there and looking for the laboratory results that we can bring to bear for the testing. Extremely important in the case, again, of Zika is there's at least 3 levels of partnership that need to be coordinated. There's the federal level, the CDC. I regard the CDC as folks who are, if you will, kind of the authorities of scientific knowledge about Zika. There's our agency at the state level, DSHS. But in the state of Texas, we're a home rule state, and so many of the local communities, cities, and counties have their own health departments, have their own assets, and really they have their own autonomy and authority over their areas. But what we want to do is coordinate with them, and I know we have good partnerships with them. We really all need to be able to share the same facts and come to the same conclusions about the facts that we see in terms of making any announcement about local transmission. So characterizing a case of local transmission, we hope, will be a very collaborative, again, between the state, local, and national authorities. And that's because of that, again, potential to create great anxiety, confusion, and concern. We have the ability to define as precise as we can an area for recommended testing in pregnant women if local transmission would occur. And again, that's part of what you're seeing going on in Miami. We would want to define that area in close coordination with local and federal partners. And that really means outreach and testing, particularly to the human populations that we believe may be at the center of that transmission. Again, as you saw in Miami, we would like, ideally, to be able to define it in such a way that we're really working within about a square mile or so of some public landmark or intersection, rather than, for instance, naming a particular street or a particular address on that street. We do want to be able to provide testing to all pregnant women who spent significant time in that defined area. And we want to be very alert for any signs that the demand for testing outstrips the capacity. Areas of concern may grow or shrink depending on how events unfold. Obviously, the more precisely we can define them, the more we're able to direct our efforts. On the next slide, we want you to know as much as you can and use the universal Zika countermeasures. Again, as I said before, the tools that we have if Zika gets here are really the very same tools that we have to prevent it from getting here at all. So frankly, skipping there to the bottom, my last point is the greatest challenge is a call to action. People ask me sometimes, gee, should I put on mosquito repellent when I go to the beach? And my answer is yes, you should put on mosquito repellent when you walk outside of your house. You should be putting on mosquito repellent when you're out doing yard work or gardening or that sort of thing, or even taking a walk around your neighborhood. The thing of it is, even though Zika presents the greatest danger to infants developing in the womb and to pregnant women, the way it spreads in a community, it doesn't matter the age or gender or whatever else of the person. It just spreads from person to person. So this is a great opportunity for people to band together and realize that when they use mosquito repellent, when they take these other countermeasures and exercise them, they're really doing something to help their entire community. So I thank you very much for your attention.
Thank you, Dr. Hellerstedt. It's an honor to have you with us tonight. I want to remind you that the presentation that Dr. Hellerstedt has been using is available on our web address, www.texmed.org/Zika. That's texmed.org/Zika. We do have the results of the first polling question, which was which of the following points about Zika remain unknown. The results of the question were 16% of you thought we didn't know the proportion of pregnant women with Zika infection in areas of Zika transmission. 4% of you said you believe we don't know the likelihood of the developing baby and getting infected from the mother. 7% of you said we don't know the proportion of developing babies that develop an abnormally small head associated with incomplete brain development. And 13% of you think we don't know what factors increase the risk to the developing baby. And 60% of you said correctly that we think we still don't know the answer to all of these Zika questions, and that is the correct answer. We do not know any of those Zika questions. Dr. Lakey will now introduce our next speaker.
Thank you, Troy, and thank you, Dr. Hellerstedt. Our next speaker brings us personal experience from her practice. Dr. Catherine Epps is a member of the Texas Medical Association's Committee on Infectious Diseases. She is an assistant professor of maternal and fetal medicine at the Baylor College of Medicine and co-director of the high-risk OB infectious disease clinic at Ben Taub Hospital in Houston. Dr. Epps?
Thank you. I really picked to highlight two main slides, which are the CDC recommendations for who to test and how to follow that algorithm in pregnancy. But obviously, taking care of women considering pregnancy and those who are pregnant kind of begins before that point. So the first important thing is this is really a time to be talking to our patients, not just those in OBGYN clinics, but in numerous clinical settings about their risk and their desire for pregnancy. So currently the CDC recommendations are for women who have traveled to areas where Zika is endemic or at ongoing risk to delay pregnancy 8 weeks if that's reasonable in their reproductive history and reproductive life. And the same thing for men who are asymptomatic to delay pregnancy by 8 weeks, but for those who are symptomatic, because it's been found so much longer in semen, to delay as long as 6 months. So I think if we're not talking to patients even before they present pregnant, we're going to miss that valuable piece of information. And obviously that's a really personal conversation that's going to vary from patient to patient. And then the next important thing to even recognize who is at risk for Zika virus, because it isn't currently endemic in Texas, it takes actively screening all patients. So that includes obviously women coming into clinic, pregnant women in particular in numerous settings, but also screening men. Because there is sexual transmission, you're not going to pick up the risk of transmitting to a pregnant woman unless you're screening men and talking to them about the risk. And obviously, if you have a man who's at risk based on travel to an endemic area, that's a person who could potentially transmit to a pregnant woman and result in a fetus with congenital Zika virus. So a really important piece of counseling. So the next thing is if you have patients, you have pregnant women who are at risk based on either sexual exposure or travel history. How you evaluate what testing to begin really depends on the timing of their exposure. So either women who are symptomatic within 2 weeks, meaning the first day of symptoms if you're within 14 days, or from the last date of travel, meaning say they arrived on August 14th, they came back to the United States or came back to Texas, that would be the first day of travel. Up to 2 weeks from that point, you're going to start with PCR testing from serum and urine. After 2 weeks is serologic testing. So if you have a patient who's presenting within the first 2 weeks, you start with serum and urine testing. If they're negative, once they hit 2 weeks, then you can go to serologic testing, which is testing by IgG. And if the IgM. And if the IgM is positive, then you continue to flow down the algorithm. Unfortunately, there are many other viruses that can cross-react with Zika virus, including dengue and chikungunya. So if you end up with a positive IgM, then you flow down to repeating the PCR testing, and if negative, going to a PRNT, or plaque reduction neutralization test. And this obviously gets really complicated, but walking your way down the algorithm and following each of these steps, this box has a lot of information, but really will take you step by step down. So only if the PRNT is greater than 10 for Zika and less than 10 for dengue can you say it's a definitive Zika infection. So for women who are presenting after 2 weeks, we're really left with serologic testing. And currently the IgM is probably only positive, we believe, until 12 weeks. So if a woman is presenting for evaluation after that 12 weeks, there isn't testing currently available, and you're just moving into screening for signs of congenital Zika by ultrasound. But the women who are between 2 and 12 weeks, then you go down to serologic testing, and it falls down the exact same way it did on the more recent exposure. I think a very important part of the counseling of pregnant women is even if you have a pregnant woman with evidence of Zika infection, that doesn't automatically guarantee that you're going to have a baby with signs of congenital infection. And I find more and more that seems to be the perception of most pregnant women. So while we can't definitively say exactly what the risk is, we know from other fetal infections that if a mom gets an infection, there's only a subset that actually has a fetus that's affected and a smaller subset with a congenital infection. Looking back at the prior outbreaks, including in Yap and French Polynesia, the French Polynesian outbreak, they only estimate about a 1% incidence of microcephaly. And from here in Rio de Janeiro, more contemporarily, it was as high as 30%, but still a much smaller subset than the total number of pregnant women affected. Obviously, there's a lot more information needed to truly know the answer to that picture, but I think importantly, a maternal infection does not necessarily mean you've got a baby that's affected. And then I have a lot of patients ask, if a baby is born without signs of congenital infection, is there still risk? And we certainly know from other infections, for example, CMV or syphilis, that there is a later sequelae that we might not see for a period of time, and that's a big piece of the puzzle that we're really missing. So if you have a pregnant patient that either tests positive for Zika, or if their PRNT is positive for both, showing elevation for both dengue and Zika, it's going to result as an indeterminate flavivirus. You're going to treat them the same way. So the next important question is talking about amniocentesis, which might let you know about fetal infection. Unfortunately, at this point, there isn't any treatment, so it's largely for information for pregnant women. And then continuing to monitor them for signs of congenital infection with serial ultrasounds. Can you go to the next slide? So this is the link from the most recent MMWR from the CDC on that previous slide, and these are constantly updating. So something that's really helpful for clinicians is signing up to get these updates. We also get updates from TMA anytime there's new recommendations, and this is certainly something that's rapidly evolving. Next slide. So the next piece is, what do we do with infants that are born to moms who have lab evidence of Zika virus? And this is where it's really important for obstetricians, family medicine, and midwifery to communicate to pediatricians about moms who are at risk. So these babies need extra surveillance. So if mom has lab evidence of Zika virus or an indeterminate acute flavivirus infection, these are babies that will have different physical exam, hearing test, and laboratory evaluation. And that includes evaluating the placenta and testing the baby in serum and urine for signs of Zika virus. And then babies that end up positive will get further follow-up. Importantly, I think this will kind of let us know the total picture of what happens to these infants, and it's really important for ongoing surveillance. But it takes physicians actively communicating and letting the pediatricians know that these are babies that need extra evaluation. Currently, navigating testing, I think, is one of the more common things that people ask me about, and there are a number of ways that you can coordinate testing. So the first is through various public health areas. So either your county or your city health department or the state health department can do testing. There are some commercial-based testing, so for example, LabCorp, things like that. And then there are a more limited number of in-institution testing. So I think it's really important to know, if you have a patient in front of you, how you navigate within your system to get testing results and then be able to get them back to a patient. Next slide. And then this is, again, the reference for that MMWR for the pediatric recommendations. And again, a very rapidly evolving piece of information. So really helpful to stay up to date and follow the guidance as it's coming out. Thank you.
Thank you, Dr. Epps. Before we proceed discussing Zika and the blood supply, I have the second poll question, and then we can take some questions from those of you in the audience on the phone. The question is, when are you, as physicians, most likely to refer someone for Zika testing? Press 1 on your phone keypad if you believe it's based on the patient's travel history. Press 2 on your phone keypad if you think it's whenever a patient requests it. Press 3 on your phone keypad if you believe the correct answer is refer anyone who presents with Zika symptoms. Press 4 on your phone keypad to choose refer pregnant women with possible exposure to Zika virus from sex. Press 5 on your keypad to select both 1 and 4, travel history or pregnant women with possible sexual exposure. We will have the results later on the call. Okay, some of you have questions for our speakers, so let's take our first physician question right now. The first caller we have on the line, I believe Dr. Cameron from Austin, Texas.
Yes, I'm here.
Go ahead. Ask your question.
My question is, if a female becomes infected with Zika virus and is not currently pregnant, how long should she anticipate waiting before becoming pregnant if she is identified as being infected?
Dr. Epps, let's hand that question to you.
So the current recommendation from the CDC is 8 weeks, and that's based on about a 7 to 14-day incubation period and about a 7 to 14-day time that they're viremic, and then doubling it. So currently we're recommending 8 weeks. It's the same thing for men who are asymptomatic, but it is recommended to wait 6 months for men who are symptomatic, and that's because of it being found longer in the semen in symptomatic men. But for your question specifically, after a woman's been infected, right now the recommendation is 8 weeks.
And Dr. Hellerstedt, you've been in communication with the CDC. Any input, inside information?
Yes, that's Dr. Epps correctly stated the current recommendations. I can tell you that I have been part of discussions where there may be some revisions, and they may recommend a longer period of time, the same 6 months as they recommend for males. So that's not official yet, but I would recommend that people stay really abreast of it because it is still under discussion and further development at CDC.
So like any infectious disease event, these guidelines can change, and so we have the current recommendations now, but need to stay tuned. Do we have another question?
Yep. We've got Dr. Sarin on the line from Fort Worth. Dr. Sarin has a question.
Dr. Sarin basically asked my question, but I can kind of rephrase it. Is there a carrier state, and if so, for a female that desires to become pregnant, I mean, is there an increased risk even after the 8 weeks time frame that you mentioned earlier?
So Dr. Epps?
So currently the thought and the information that's come out is that once you've been infected, it shouldn't be at risk for future pregnancies, and there isn't sort of a known carrier state, but obviously things are rapidly evolving. So no, there isn't right now the thought that it could affect future pregnancies or much farther down the line, but again, a lot of information is still coming in.
Great. Thank you, Dr. Epps. And thank you for those questions. And we'll get back to some more of your questions in a little bit. We're going to resume our presentation. I want to remind you can follow along with TMA's Zika Tele-Town Hall PowerPoint presentation that accompanies this program by visiting www.texmed.org/Zika right now to see that presentation online. And you'll be also in the coming days be able to get it online after the call. Dr. Lakey, would you like to introduce our final speaker?
Yes, thank you, Troy. Our next speaker is Dr. Susan Rossmann. Dr. Rossmann is the Chief Medical Officer at the Gulf Coast Regional Blood Center in Houston and the Chair of the Texas Medical Association Subcommittee on Transfusion and Transplantation. Dr. Rossmann.
Yes, thank you. So I'm going to give a little information about what we've been doing with Zika to keep the blood supply safe. The first question, next slide please, is can Zika be transmitted by transfusion? That's always our first question about any infectious agent. And to be transmitted, it has to be present in the blood of a healthy donor because we only accept blood from healthy people. And the answer clearly would be yes, because 80% of those never have symptoms or up to 80% are completely asymptomatic. So they might donate blood not knowing they had Zika. Is it infectious by the parenteral route? Yes. Plasma viremia lasts 1 to 2 weeks. And yes, it survives modern blood processing and storage. Next, so it certainly can happen. And in Brazil, in fact, we have 4 documented cases, cases from 3 donors to 4 recipients. The donors, of course, were all well at the time of donation. Now, the recipients had seroconversion, laboratory evidence of infection, but actually no clearly attributable morbidity, which is interesting and has happened with some other viruses. In Puerto Rico, screening of blood donors has shown that up to 1.1% of donors have Zika viremia by a screening test. So that's a pretty high number. Next, Our strategies of reducing risk are somewhat limited. Donor screening is the first one and the most important one. The first and most important item is the history of travel. If you have not been to an area that has Zika, you are unlikely, very unlikely, to have Zika. So those are the first questions we ask about where you've been in the last month, or if you have had sexual contact with someone who might be at risk of Zika. Another strategy is to test blood for Zika. This is investigational at this point. We are using NAT, which is a PCR type or another type, similar type of nucleic acid testing. As I said, there's a 1 to 2 week period of viremia, which is a fairly low-level viremia, which is somewhat challenging for testing. And some centers in Texas began testing in May, others later. Some are testing all donations, others selectively. Next, another strategy of reducing risk is a completely new method of pathogen reduction that has recently been licensed. It can treat virtually all but viruses, bacteria, and parasites, known and unknown, which is attractive, but it is only available for platelets and plasma. There is no red cell system yet. And it is expensive and just getting underway, really, in this country. The FDA, next, please. The FDA, which is our regulatory agency for blood, issued in February some guidance involving donor screening by asking questions about travel and sexual disease. The travel question in particular resulted in a substantial loss of donors in some areas of Texas, notably the Valley. This guidance also said that in areas with active local mosquito transmission, which of course we fortunately don't have in Texas yet, we are not allowed to collect blood unless we can either test it or pathogen reduced it. Next, the FDA revised this guidance in the light of the ongoing spread in the United States and the regional epidemic in August, just about 10 days ago, to declare that within 12 weeks, all blood in the United States is to be tested for Zika. In Florida and Puerto Rico, they mandated immediate testing, and in 11 other states, they said that testing should be begun within 4 weeks. Texas is one of those states. Otherwise, the Gulf states, because of the risk of local transmission, and California and New York because there are such a large number of travel cases there. Next, the cooperation with public health. I think the blood centers, as we have undertaken this investigation and worry about local transmission, we have been reporting, or we will report, we have not had any local cases yet. We will report any positives as we do this screening to the local and state departments of health using exactly the mechanism we do for West Nile and have used for many years successfully. Department of State Health Services is working with all collectors in Texas to develop appropriate communications. Next, our experience with testing has been no confirmed positives from Texas sites, over more than 80,000 tests. There are a few that are possible from Florida, but they have not yet also been confirmed. That is, cases of donors being positive. There have been no transfusion-transmitted cases in this country that I am aware of. There is ongoing concern about two things: the cost of this testing and many implementation issues, because obviously getting all this testing up within 4 weeks or even 12 is very intense work and very rapid response, and so we have a lot of work to do. So thank you, Dr. Lakey. Back to you.
Thank you, Dr. Rossmann. We now have the results of our second poll question about when are you most likely to refer someone for Zika testing. 4% of you said refer based on a patient's travel history. 2% said you refer whenever a patient requests it. 8% refer anyone who presents with Zika symptoms. 9% of you refer a pregnant woman with possible exposure to Zika virus from sex. And 77% of you selected both 1 and 4. You refer based on a patient's travel history, and you refer pregnant women with possible exposure to Zika virus from sex. The answer is the last one, both 1 and 4. Physicians are recommended to refer patients for Zika testing based on the travel history and for pregnant women with possible exposure to Zika virus from sex. Now Dr. Hellerstedt, Epps, and Rossmann are ready to answer more of these questions. The next caller we have on the line is from New Braunfels, Dr. Michelle Kohler. Go ahead.
Hi there. I would like to know how long it usually takes to get results from the lab testing, and also if this testing is usually covered by insurance or if there's a significant cost to the patient.
Dr. Hellerstedt, I think that'd be a good question for you.
Yeah, I can speak to our state lab, and so for the PCR testing, it was 1 to 2 days after we receive the specimens. And we would recommend, again, that you go to our website, www.texaszika.org. On that site, it has all the instructions about the testing. And then for the IgM, we're talking about 3 to 4 days, again, after we receive the sample. Remember, though, that when PCR testing, if you get a positive, you're done. If you get a positive PCR, I'm being 2 to 3 days for PCR, 3 to 4 days for the IgM. So remember, if you get a positive PCR, you're done. You've pretty much proven that the patient has Zika infection, whether you're getting it from the bloodstream or from the urine. We can do both types of testing. And for the IgM, basically, if you get a negative IgM, then you're, again, pretty much assured that they don't have antibodies against Zika. But there again, I'm trying to be very careful in the way I phrase that, because the timing of when these specimens are collected can have a lot to do with essentially how reliable the tests are. Obviously, when you're testing for the virus itself, you're looking for that relatively narrow period of time when it's present in the bloodstream and they're actively viremic. We think there's a slightly longer period of time, maybe an extra week, where it's detectable in the urine. But then you don't even begin to get the antibody response for 10 to 14 days after you've had the infection. So again, depending on when you collect which specimen and which test, you may be higher or lower on the reliability curve in terms of what those results mean. If you get a positive IgM test, a positive serology test, you're usually not done, and what has to happen after that is the plaque reduction neutralization test, which currently I believe is still only being done by the CDC, and that's where I know folks are experiencing some significant backlogs there. That is, both the serology and PRNT are not very scalable tests.
Dr. Epps, you've been ordering these tests. What is your experience getting the results back?
I agree. The PCR testing is coming back really pretty rapid, and when we've had positive IgM that goes to PRNT, it's a longer wait. It does seem to vary a little bit with the exact point it's sent, but sometimes even as long as the 4 to 6 week range. But PCR is very rapid. Okay. And in Houston, we're utilizing at one location we use an institutional test, but otherwise it's through the City of Houston Health Department.
That's good to hear from the front lines.
And as far as insurance coverage, I wouldn't really be able to speak to private insurance. I do know that Medicaid, for instance, will cover all of the diagnostic tests that have to do with the evaluation of Zika.
Okay, good.
All right, let's go to our next caller. We've got Dr. from Pearland, Texas, Dr. Roost.
Well, after some of the answers, this may seem silly, but the symptoms and signs initially are quite nonspecific from what I've read. Is there some particular, other than finding somebody from an endemic area, is there some particular sign or symptom that would be more pathognomic or make me send somebody for testing?
Dr. Hellerstedt?
Yeah, and I'll ask Dr. Epps to weigh in as well. But basically, for one thing, we will now accept testing for folks who do not have travel if they have 3 out of the 4 major symptoms. Apparently, one of the more pathognomonic of them is actually the rash, which in many cases is often very pruritic rash. So if you have a pruritic rash and any of the other symptoms, arthralgia, conjunctivitis, or fever, We recommend if you want to test that patient, call your local health department, have a conversation with us, and basically if that really seems like they have the symptom constellation, we will do the testing. We will also do the testing for anybody who has 3 out of those 4 major symptoms.
Okay, let's go to our next question. Doctor from Fort Worth, Texas, Dr. Christopher. I'm sorry, Dr.
Hi, I had a twofold question. One, is there any other long-term sequela from Zika other than the microcephaly that occurs in the fetus? And the second part of the question is there any treatment recommendation for the Zika positive infected patient who is symptomatic?
Dr. Epps, let me give this question to you.
Thank you. So, you know, the number of things that appear to be associated with infants infected by Zika is certainly so. Microcephaly probably is not, well, certainly is only the tip of the iceberg. So there are a lot of intracranial findings that we're seeing on ultrasound that start out with calcifications or enlarged ventricles, abnormalities in the baby's cerebellum and posterior fossa, sometimes the really absence of brain material, and then microcephaly. In addition, joint contractures or something called arthrogryposis, eye abnormalities that you can even see on ultrasound and go along with deafness. There's been a recent report looking at congenital deafness, so it certainly goes along with other congenital infections. There's an increased risk of both miscarriage and stillbirth during pregnancy. And I think the picture of what this means long-term, certainly for babies with microcephaly, extrapolating from other infections, we know that's most likely to be really profound and serious. But some of the other things that might not show up for a while, I don't think we have a good answer. But more and more every day, they're adding to the list of findings that affects infants with Zika.
And again, Dr. Hellerstedt, you've been in the conference calls with the CDC. Any information you're gleaning from those calls related to a broader spectrum of illness?
I think Dr. Epps covered it completely, really, in terms of what we know or kind of suspect. We suspect that it has, it's especially able to attack any kind of growing nerve cells. So even in adults, the kind of replacement that we have for some of our brain cells may be affected by Zika infection. And then, of course, you know, there is an incidence of Guillain-Barré in adults post-infection, but I believe the question was really about the developing fetus and the newborn.
We have time for one last question before we need to conclude. I'm going to go to our caller, Dr. Gupta.
Yes, I was wondering if there was a mosquito surveillance going on in our area and the mosquito tests positive, how far the area extends and whom do you offer the testing to if the only mosquito is positive?
Hi, this is John Hellerstedt. Basically, our surveillance really has to go through human disease that we detect. There is a role for the detection of the virus in mosquitoes, but it's a very limited role. So basically, you could go out and test 1,000 mosquitoes, and if they were all negative for Zika, you wouldn't know that the next mosquito over didn't have it. Likewise, if you know that there's transmission in an area and you go out and test the mosquitoes and they're positive, it's really sort of telling you something you already knew. And so again, in the case of Miami, that's a very good case in point. They were doing surveillance. They were catching mosquitoes, but it was only sort of within the last week or so of a 4 to 6 week outbreak that they actually identified the virus in mosquitoes. So testing mosquitoes for the Zika virus is not an especially good way to do it. Rather, we'd be looking at human cases. We'd be going out and doing that case-specific epidemiological investigation, trying to understand where the person was, where they spent time, where they might have been exposed to the mosquitoes, and then otherwise try and link any cases that might be present to that case.
We want to thank everyone who stayed on the call. Our goal is to help you be as prepared as possible for the serious public health threat of Zika. I want to offer a special thank you to our moderator, Dr. David Lakey, and to our speakers this evening, Commissioner John Hellerstedt, Dr. Catherine Epps, and Dr. Susan Rossmann. You can send us an email anytime at knowledge@texmed.org. For those who want more information, I encourage you to visit the Department of State Health Services Zika webpage, which is www.texaszika.org. Texas Zika is all one word, or the TMA Zika Resource Center is at www.texmed.org/ZIKAs. We want to thank again our physician leaders, and most of all, we thank all of you for joining TMA's Tele-Town Hall on Zika. Good night.